DSA, and I will be your MC for today. We have an amazing lineup of speakers for you, and a team of Houston DSA members has been working many weeks to put together a program that would bring the conversation about healthcare and worker justice forward. Our hope is that through this event, that you'll be inspired to talk to your family, coworkers, friends about the necessity of both Medicare for All and paid sick leave, and that you will join us in our campaign in bringing these things to Houston, Texas. Now, there's a very real possibility, or even probability, that someone told you, why fight for Medicare for All in Texas? Or paid sick leave. It will never get done here. That person might have even been a Democrat. But I digress. I might be a starry-eyed socialist. I know that Greg Abbott will not be joining us here today. I know that Ted Cruz will not be co-sponsoring Bernie's bill in the Senate. And we all know how much certain people in the medical district will fight this bill kicking and screaming. But I'll let you all in on a little secret. Medicare for All, paid sick leave, that's the least they could do for us. How many of y'all were impacted by Hurricane Harvey? I know a lot of us here were. I've been through mold-infested homes and streets lined with soaked furniture and clothing. And let me tell you, the recovery of Houston is being borne on the backs of the under and uninsured. Our poorest and most neglected neighborhoods, the black and brown neighborhoods, not only were flooded out, but they are the people that are putting our city back together. The least we can do for the families that lost all their possessions in earthly security is giving the assurance that medical costs won't drive them further into poverty. Planes can take off, cars can go down the highway, and building cranes can scratch the sky, and you can even get your breakfast taco made this morning, all because of the workers that make it happen. So when I look across this city, and I see all the gleaming cars and towers next to homes where families must risk being fired when they want to take care of their sick, I tell you, this is the least of our demands. The bottom line is this: if we can be the energy capital of the world, if we in Houston are to live up to being the dynamic city that we so often claim to be, but we cannot provide health justice for everyone in our city and state, then we are not worthy of the boast. After Harvey, Abbott, Cruz, and the rest of the Republicans have sat idly by and let Houston fend for itself. And for most of its history, this state has actively denied health insurance. 4.5 million Texans are uninsured. Undocumented immigrants are virtually barred from any means of public insurance. Those seeking abortion are subjected to a 24-hour waiting period. We cannot tolerate this any longer. Our comrades in Austin have showed us that when we fight, we win. So why Houston? Because it starts in our workplaces, in our homes, in our streets. But it for sure will not start without you. So I will turn it over to Amy, who has a couple of other words to share with us today.
Hey, y'all. My name is Amy Zachmeyer, and I am a co-chair with Houston DSA, but I'm also on the Medicare for All organizing subcommittee for our national campaign, and I co-lead the National Medicare for All Regional Organizer Program. So I actually am really unsure how I found myself here. I have extremely chronic imposter syndrome, and I'm not even sure Medicare for All is going to cover that. But I am proud to call myself an activist and an organizer, and I still think every day, like, whoa, like I'm an organizer. And I just keep myself really busy, and there really is so much to do, and I can't give myself much time to question whether or not I belong here, because there's organizing to do, and right in this moment there's a speech to give, and for some reason I am at this podium, so I guess I'll give y'all the very best speech that I can give. When I'm done, a speech will have been given, and amazing speeches will have been given here by our comrades today, and this event will have gone just fine, and some of you might even come tell me that I've done a good job, and I'll think to myself, well, it was at least good enough. And then I'll go home and feel really fulfilled because I came here and I believe in the work that we're doing. So the stuff I'm about to tell you is really good information about how we're going to win Medicare for All. We do see a path to victory, and we really don't give a damn if our current elected officials don't want to see it happen. This isn't about them, this is us, and this is our movement. Now let me tell you exactly what I mean when I say Medicare for All. Some of you may have heard a lot of different versions or even a few myths about what Medicare for All is. So let me make it really clear what we are demanding when we say Medicare for All. A single health program. Everyone will be covered by one health insurance program administered by the federal government and have equal access to all medical services and treatments. Comprehensive coverage. All services requiring a medical professional will be fully covered. You go to the doctor of your choice, and your dental, vision, mental health, and pharmaceuticals will be included as well. It'll be free at the point of service. There won't be those co-pays, there won't be fees. All healthcare costs will be financed through tax contributions based on ability to pay. No co-pays, no fees, no deductibles, no premiums, ever. The coverage will be universal. All United States residents, non-citizens included. And those who have lost their jobs or are affected by the transition to government-run healthcare will have a jobs initiative available to them so that they aren't negatively affected by all of us receiving healthcare justice. At the historic 2017 National Convention for DSA, we voted to make single-payer healthcare a top priority. The national DSA Medicare for All campaign was started as a result. For some reason, they called me and asked me to join, and so I said okay. And I'm not, again, sure exactly how I got here, but here I am. One of our top priorities in the campaign is that we know this work cannot be done at a national level. We can't just, get together, plan some stuff, and hand it down to the chapters and say, now you do it. Because we know that we have 35,000 members across the country. We know that some chapters have about 15 people and some have 1,500. Some chapters are in cities with a deep history of activism and left politics, like Chicago and New York City, but some chapters are in states that have tried to pass their own single-payer bills, like California. On the other hand, we have chapters like ours. Like, we're in a state that's a red state, a right-to-work state, a state where a hurricane devastated our city, and the governor moved just a little slowly because the city is just a little too far to the left for his liking. DSA believes in the people in all of these states. Our campaign is designed to give everyone the opportunity to organize in the best way they can for their chapter within their own political climate and build a tool set that everyone can use. Many people actually don't know this, but they have the idea that, we're part of the national campaign, and so we were handed the list of 35,000 people and told go out there and organize. But that's actually not how it works. They don't just hand out your names when you join DSA. And they didn't give us this really long contact list. We had to start somewhat from scratch. Not quite. I mean, we had the infrastructure there, but we didn't have the list. But now we already have 80 chapters nationwide that are signed up to work on Medicare for All across the country. So I'm about to throw a bunch of details at you. Get ready. It's a lot to go over in a short time. But I'll be happy to answer any questions that you have later on. I'll be here for a little while doing cleanup, and I'll be happy to let you hold the trash bag while I fill it, and I'll answer your questions. The campaign is composed of a steering committee, an organizing subcommittee, a political communications subcommittee, a political education subcommittee, and a political subcommittee. I'm not sure why all of them have the name political in them, except for the political subcommittee, but, it is what it is. The steering committee is chosen by the NPC, which is our highest ruling body, and it includes members of each subcommittee, and they work together to make sure that the work that we each do is done in concert with one another, and they give us direction on a bigger vision. The communications subcommittee is responsible for the beautiful website that you can all visit after I get done speaking at medicareforall.dsausa.org. They make the graphics that you see on our national campaign stuff, and they make the graphics that you get on things that you might get in the mail about Medicare for All. Then we have the education subcommittee, which is exactly what it says it is. They work to make sure that our membership have the most informed activists out there, and the political subcommittee works on the political messaging of our campaign. That leaves us with the organizing subcommittee, which I happen to know the most about. The organizing subcommittee's first task was to come up with a guide to help chapters build their campaigns. These guides are not mandates, but are meant to be a toolbox from which chapters can pick and choose what works best for them and meets their organizing needs. Many aspects of our organizing guide are designed not only to help chapters with Medicare for All, but could act as a basis for building other campaigns like paid sick leave. Houston DSA was responsible for working on the part about how to host a town hall, and so I'm gonna let you guys judge how that guide worked out. All in all, we worked together to build what we call a campaign in a box. Chapters all over the country purchased these boxes and have been using the website, again, medicareforall.dsausa.org, to plan educational events, town halls, speeches, canvases, and more. When we finished that guide, though, our work wasn't done, it was just beginning, and it was time for us to organize. The organizing subcommittee knew that 3 to 5 socialists that live in different states across the country were not enough to build the vision that we have for a national DSA Medicare for All campaign, so we enlisted the help of regional organizers. There are 7 regional organizers so far, and this number is likely to expand. The regional organizers are tasked with connecting all 80+ chapters that have signed up to work on this in almost all 50 states with national resources, but also connecting them with one another. We can learn and grow from one another, and we are making a truly national push for healthcare justice. We lift up and highlight the work of chapters, and it's turning out to be something really beautiful. It's honestly going even better than I expected, and this weekend is our National Weekend of Action. Over 40 chapters across the country and thousands of people like you are doing work this weekend, and everyone here is a part of it. So when you take pictures today, make sure you tag them with hashtag DSA M4A. And when you leave here, check out what you find when you search DSA M4A, because I think you'll be proud to be part of it, and I think that you'll be inspired to stay involved, and I hope that you'll decide to start seeing yourselves as organizers and activists too. A little later, our comrade Dan is going to talk to you about our local work. Austin DSA and Workers Defense Project are going to talk to us about the fight for paid sick leave. And we know that all of you came here today for a reason, and we really appreciate that. You know that our system is broken and we deserve better. Together, we are going to demand better. Thank you for the time that you took to be here today. I look forward to the future that we're going to build together.
Thank you, Amy. Next up, we have Tyler James and Sasha Leggett from Workers Defense Project. Tyler James is the political director for Workers Defense, a statewide organization dedicated for better working conditions for low-income Texans in the construction industry and to empower those people to participate in the electoral and advocacy process. He has worked in Houston and Texas politics since 2012. Previously serving as a political advisor to Amber and Steve Mostyn, working to help organizations that are creating access and power for working people on the issues that affect their lives. He has worked on state and local races around Texas, working as a field organizer, field director, and campaign manager, most notably working on the Harris County Project and Sylvia Garcia for Texas Senate campaign. Sasha Leggett is currently the business liaison of the Better Builder program for Workers Defense Project, a 501c3 nonprofit organization that advocates for the better working conditions for low-wage workers in the construction industry. Previously, Sasha served as a federal government professor at Tarrant County College in Arlington, Texas, where her students are engaged in learning the legislative process and impact legislation has on society. She is a graduate of the University of Georgia School of Law, where she obtained her Juris Doctorate, and Clark Atlanta University, where she obtained her Bachelor of Art in Political Science. Sasha's passions for restorative justice are reflected in her work as a legislative aide for the Georgia State Senate, externships at the United States Department of Justice, and United States Department of Education. Office for Civil Rights, as well as her work as a high school social studies teacher through Teach for America Corps. So without further ado, Tyler and Sasha.
How's it going? Sorry. So we're going to talk a little bit about paid sick. So we both work at Workers Defense, and like Nick said, Workers Defense, we work to advocate mostly for low-income construction workers and for policies that will improve worksite safety and just generally improve their lives. Okay.
You got to speak up.
Yeah. So we're going to talk a little bit about paid sick and our role in the paid sick campaign in Austin and our role statewide for paid sick. And so just generally speaking, when we talk about issues that we're fighting for, we worked with a large coalition in Austin and a large coalition statewide. And the first question we asked is, what policy can we fight for? I think we all got together and realized that collectively, we've gotten very good at organizing people and bringing people to Capitol to fight against things. But it was time to find something that we could all collectively work on and fight for. And so paid sick time is one of the things that came out of there, and just the real quick just talking points on it. Paid sick is something that not everyone in Texas has access to, and 40% of Texas workers don't have access to earn paid sick time. Those workers are overwhelmingly in the construction industry, in the retail industry, and in other types of service industries. And so working with our coalition partners, which in Austin included Center for Public Policy Priorities, Young Active Labor Leaders, Fight for 15, Unite Here, Deeds Not Words, Planned Parenthood, DSA in Austin, Indivisible, and the Austin Safe Alliance, Progress Texas, a very long list of progressive organizations who all work on many different issues. But paid sick is one that stuck out. These are all membership-driven organizations. It was a policy and an issue that affected everybody's membership. And so the thread that we can all organize around is, while we have our members and we fight for their rights and worker safety on construction sites, they also don't have access to paid sick time. When we think about organizations like Planned Parenthood, they provide services to people in the community who oftentimes, like was mentioned before, to get those services have to go through a 24-hour wait period, and oftentimes have to take off time from work, and they aren't compensated, and they lose money. And at the end of the day, the people we're talking about that are affected, they're low-wage workers, often working hourly jobs. And what that translates to is, if you get sick, or your kid gets sick, or your parents get sick, or your brother has to go to the doctor, and anybody in your family, you're taking to the doctor, you're sick, if that happens 3 times in 1 month, for a low-income family, that's their entire month's grocery budget. And so something needed to be done here, and this is sort of where we landed on organizing. And so to start in Austin, the campaign began with all these groups on September 28th, which is Labor Day in 2017, and had a rally asking the city of Austin to pass an ordinance, or not an ordinance, but a resolution exploring the issue and to start the process for creating this work in the city. And that's the first day of the campaign. Just generally how the campaign worked, and sort of getting into what's going on, because I think y'all are driving something here in Houston. The campaign was a true coalition. There are organizations that existed across the spectrum doing this work, all collectively coming together, setting a goal, creating the path for how do we get to that goal, creating targets, finding the exact path, basically creating a campaign plan. Like, we know what we need to do, we know what the victory is, we need to know all the steps to get there, and everybody agreed on, this is how we're gonna do it. We had, we're not gonna go through the committees, but the Work Strong Austin coalition had all of the same committees, and all the work was done through the committees. The decision-making process was clear, it was organized, and everybody was committed that when the coalition made a decision, that's what everyone was working towards. And so all of these organizations got together. We had stakeholder meetings, which included community members, members of the Chamber of Commerce, members of the business community, all types of organizations. One of our staff members puts it, basically Parks and Rec meetings. So if you watch Parks and Rec, it's a meeting where everybody gets in the room and everybody yells at the person holding the meeting. And at the end, the goal is to try to come up with a policy that everyone there can agree on. And at the end, that was the goal worked towards in Austin, right? Ultimately, not everyone agrees on the policy. There are chambers of commerce and business entities, the restaurant associations, people like that will never agree with any version of a paid sick policy. But the process was done, people had input, and the policy that came out in Austin reflected negotiations with all stakeholders and what the community wanted. And on February 15th, the city of Austin became the first city in the South, in the U.S. South, to pass an earned paid sick time policy. So for the coalition, the work doesn't end there, right? Like, when we're dealing with legislation, there's passing the legislation and there's actual implementation of the legislation. There are rules associated with companies. They must put up signage, that everybody has to follow certain steps to be in compliance with the law. And so the Work Strong Austin Coalition currently right now is working with the city government officials to work through that implementation process and make sure that the efforts didn't end with the passage of the ordinance. The efforts just continue, right? Because we want to make sure that we have the ordinance, but now we want the ordinance to be implemented effectively. And for instances where there are bad actors not following the policy, there's a way to call them out. There's a way we put them through the process and we bring them back into compliance. So the entire coalition is working with the city to go through that process. And so I'm going to shut up for a second. I'm going to let Sasha actually talk about what the policy looked like, so we can get an idea of what a paid sick policy in Texas looks like.
Okay, can you guys hear me? I don't think I like this.
Yeah.
Okay, I'm going to speak into this mic. I like this mic a little bit better. So it's ironic that people in Texas seem to think that this is like some crazy idea. Like, why would people want to get paid just in case they were sick so they could take off time and take care of their children? Like, where is that idea even coming from? It's almost like here we think that it is ironic or unheard of. And this has actually been something that's been going on around our country since 2006. Okay, so since 2006, there's 43 municipalities, including 11 states, who have passed paid sick policies in their areas. And so we're actually on the tail end of things. We're kind of just now trying to come up to speed. And so what we're saying is that the families here in Texas have waited long enough to be able to take advantage of some of these policies that not only they deserve, but they actually really need to make their lives better. And so the policy in Austin that was passed highlights a couple of different things. So it applies to full-time, part-time, as well as temporary workers who work in the city of Austin at least 80 hours within a calendar year in the Austin city limits. It allows those workers to earn up to 8 days or 64 hours if they're employed by businesses that have more than 15 employees, or 6 days or 48 hours a year if they're employed with a business that has less than 15 employees. Employers are supposed to give out a printout of a statement of all the paid time accrued by their workers once a month so that employees know exactly how much earned time they have accumulated. And then employers are also supposed to compensate the employees based on their pay that they've gotten. Now, we'll probably think about this because we've talked about it that, people who work in the food service industry, specifically those who rely on tips, how would they get paid? So employers are supposed to pay them at a rate of $7.25. So if you're a restaurant worker and you usually are making $2.13, when you get paid time off, you're going to get a rate of $7.25, okay? So that's one of those things in the policies. In Austin, the policy is set to go into effect on October 1st for businesses who have, for most businesses, but if you're a business that has 5 or fewer employees, then it'll go into effect on October 1st, 2020. And my favorite part is, how do we hold people accountable? How do we make sure that people are going to be in compliance? So what happens is, if you find an employer who seems to be out of compliance with the policy, you can make a complaint to the city. Their job is to do an investigation, and if they find out that an employer is not in compliance with the policy when it goes into effect, they can charge or fine that particular business up to $500. So what we're doing is we're trying to start here with what we have in Austin and start to build upon that to make the case for the 40% of workers around Texas who don't have access to paid sick days. And we want to continue to make that case to make it a statewide policy so that everybody in Texas can have access to paid sick days, because they deserve it. They're our working families.
I'm gonna like move that. I feel like weird.
Yeah, I mean, it's
standing
so
and leaving
weird.
this.
It's like, yeah.
So, pass the policy in Austin, what happens next? What are all the organizations doing? What are we working towards? I'm going to talk a little bit about we call it a statewide campaign, but it's a multi-city campaign to get paid sick time. Right now, and some people have seen it, some haven't, we just launched 2 different paid sick campaigns, one in Dallas and one in San Antonio. In both of these cities, the ordinance looks as substantially similar as possible to the city of Austin. You know, in different cities there are various changes in code and enforcement mechanisms and things like that, but the thing that's exactly the same is the policy, right? You earn the same amount of hours, you earn them at the same rate, and it applies to all workers in both of those cities. The biggest difference between Austin and Dallas and San Antonio is the campaign is not being done. I'll mess with you a little bit, move around, I'm sorry. Sasha knows this, like in our office, I can't sit still, and
He's
so
a
standing
pacer.
like in this space is, it's causing me a major heartburn. But, so the big difference between both of those is we're not going through the inside process, right? We're not taking advocates to city council and relying on council members to take the policy and pass it internally within themselves. In both of those cities, we are putting the paid sick time policy on the ballot. And we're doing that through a petition process. And so what we're doing in those 2 cities is we're not saying 8, 9 council members in this city say, you all have paid sick time. The reality of what's going to happen is more than 50,000 people are going to sign a petition saying we want to make a decision as a city and put this on the ballot. And then in November, more than 200,000 people in each city are going to vote and say, we want paid sick time. This is not something we're relying on our elected officials to give us. We went out, collected the signatures, and we voted on it and gave it to ourselves.
That's right.
Which is it's a big deal, and it's something that's going to help us going forward when we're talking about what does advocating for a statewide policy look like. Advocating for a statewide policy is creating basically an army of people that took their time, energy, and effort and went out and tried to get this policy passed, and they have a stake in the process. And so when we're going to Austin and we're talking with state legislators about, they will call it preemption, right? You can only preempt something that hasn't happened yet. At this point, 2 cities will have passed it through the ballot initiative process, and the city council will have done it. It's not going to be preemption, it's going to be them taking something away. And so we're going to have hundreds of thousands of people that chose to do this themselves, and the state government is going to have to look at all those people and say, we don't think you, 1, have the right to make decisions for yourself as a city, and 2, we don't think that you deserve paid sick time, which is a tool in fighting the legislation that we haven't often had, right? We're not all collectively going to the Capitol and fighting for something that hundreds of thousands of people have taken an action to implement. And that's the big part of what the statewide campaign is. And the statewide campaign looks extremely like the Austin campaign, right? It's the same organizations with a little bit more local flavor. In San Antonio, we're working with a couple of different local San Antonio organizations. We're working with local San Antonio DSA. We're working with Move San Antonio. And in Dallas, sort of looks the same, right? It's the local versions of the organizations that are we're at the Austin table. And there's a collective of statewide organizations that are a part of it, one of which is Workers' Defense. We have Planned Parenthood, Texas Organizing Project, Texas Freedom Network. I'm going to leave somebody out. The list is very long. But we're all working together to get these things on the ballot and ultimately get them passed with the goal of being able to go into the next legislative session and being able to have some ground to stand on and sort of defining and us saying what the battlefield is going to be on this, right? We always let them pick the battlefield. We let them say we're going to go after plastic bag bans and we're going to go after fracking bans. And in this instance, we're choosing what they have to fight on for them, and it's going to be an instance where they have to take away a policy that affects the lives of hundreds of thousands of people directly and millions of people indirectly.
I think that's it.
I think that's what we got. I don't know where we're at on time, but we'll finish a little early, and then I'll be in the Q&A panel if people have any other questions, and I'll be sticking around too if anybody just wants to talk about unpaid sick time. Paid sick time. Paid sick time. We talk about it as time, right? And we say earn. That's one thing. It's one thing to say we're going to give people paid sick leave. What we're doing is actually giving people the right to earn paid sick time, right? You work 30 hours to earn an hour. That's not something somebody gives to you. You earn that.
Yeah.
And that's what we're doing throughout the state. And look forward to talking with y'all later. And thank you for having us.
Thank you. So in Austin, for businesses, for larger size businesses, the implementation starts on October 1st, 2018. If you have a business, a small business with 5 workers or fewer, then you'll start in 2020.
Thank you so much, Tyler and Sasha. The analyst at Farm and City. At his day job, he advocates for equitable, sustainable land use and transportation policy throughout Texas. Outside of work, he joined DSA this past summer after graduating from the University of Texas at Austin in May 2017. He has been heavily involved with major chapter initiatives since then, including winning paid sick days in Austin, rejecting a police union contract on the basis of cost and accountability, and being elected to the new Leadership Council as an at-large member. So Ashkan, welcome.
Paid sick days was the perfect, is this all right? Paid sick days was the perfect campaign for us in DSA. Externally, it built on the storied tradition of limited but significant advances for workers' rights. Internally, in a fragile environment, paid sick days gave Austin DSA a unifying cause to organize around and really build our organization with. Before we formed a Health Justice Committee, we were capable of scrapping maybe 20 people together to canvass about whatever particular local issue came up that month or show up to some protest or whatever. We lacked a process to identify and achieve real advances in social and economic justice. We could talk theory all day long, and we could tag along with whatever campaign someone else was doing, but we couldn't yet marry theory and praxis in an effective manner. Austin DSA was not a political force in the city, and now perhaps it is. Certainly far more so than 6 months ago, and we are getting louder and stronger. Happy to talk about that later with anyone if you're interested. There were a lot of reasons for the state of our organization at that time, just after the convention last summer, which I will absolutely not go into. I will just say that a shared leadership structure is generally preferable to one old white guy running shit, and y'all seem to have figured that out. Congratulations. Anyway, we're much stronger today, and we helped pass a citywide ordinance that by back-of-the-envelope math is at least a $50 million transfer of wealth annually from businesses to the working class. We've developed dozens of effective socialist organizers who are proud of their accomplishments and eager to capitalize on that momentum and the institutional knowledge that we are developing as an organization. Now I'll tell the story of the campaign from Austin DSA's perspective. In October of 2017, my friend James Cole established our Health Justice Committee. Thank you, Tim, for that branding. It's excellent. As Amy covered, Medicare for All is one of DSA's national goals established at the most recent convention. Texas in particular suffers from inadequate coverage. State lawmakers, just as one example, reject federal Medicaid expansion funds that provide some sort of coverage for around 900,000 Texans. So we clearly had a problem. Where Austin DSA might be able to contribute to the health justice movement wasn't immediately obvious. It's difficult, for example, to get a bunch of young, angry leftists excited about signing people up for the ACA as a way to dismantle capitalism. Other chapters had demonstrated the potential of canvassing for Medicare for All to attract hundreds of participants, but Californians had a statewide bill that could excite any given local whose door they might knock on, much more so than a federal level initiative. We've heard stories, maybe apocryphal stories, but I don't think so, about East Bay adding dozens of new dedicated cadre members from their canvassing efforts alone in a sort of wonderful positive feedback loop of socialist organizing. This really excited us, both what it could do for the movement and for our organization. It was also clearly enabled by the local, more direct ask in a way that Medicare for All couldn't necessarily replicate in Austin. As much as this was a campaign spurred by the budding national movement around single-payer healthcare, its success and execution was directly facilitated by this, again, local ask. Tyler and Sasha described how the overall paid sick days began in Austin. From DSA's perspective, timing of our involvement was perfect. The campaign was already well underway and approaching a vote in just a few months. A few of us at Austin DSA had gone to City Hall in September when council initiated the stakeholder engagement process. And now we were looking for some way to meaningfully contribute to the national effort of Medicare for All. It was a perfect opportunity. Once we put two and two together, the path ahead was fairly straightforward. Before I dive into canvassing specifically, I want to touch on the other main advocacy outlet for this process that I've seen get less attention than I think it should, stakeholder meetings. Maybe not directly relevant to this campaign for y'all, but still kind of an important thing in municipal initiatives. In-person meetings have inherent accessibility limitations, and the digital divide creates an obstacle even for the alternative options like texting or online forums that were offered to us during our stakeholder outreach process. Fundamentally, working class people are generally not already engaged with local politics. They will not know what's going on. Their voices will not be heard. But the business class, local chambers of commerce, and so on keep a very close eye on such matters. They're organized. They show up to these meetings, and then later they get to somewhat legitimately frame their participation and their talking points as reflective of the community. There's an argument out there that because the deck is stacked against us at things like stakeholder meetings, it's not worth going. Members of city government, and of course the business members there, can be dismissive towards socialists who show up at public hearings. But it's important for leftists to start taking up time and space in the processes of governance. Government officials need to know that we're there, we're the people, and the people in the community who are skeptical about us need to know we're there too. Like a lot of people are skeptical of our level of seriousness and dedication. We need to prove that throwing your lot in with the socialists is a better bet than leaving it in the hands of professionals. Yeah, professionals. Yeah. Participation in government-held stakeholder outreach efforts, then, is not capitulation to an uneven battlefield. When we do it, we should show up with a hard party line and avoid making gulag jokes. This has a real influence on policy. Input at these meetings informs policy, and it gives the few decent electeds that are around ground to stand on for proposing the boldest possible reforms, and it lets people who are curious about socialism hear our ideas in practical terms that are directly relevant to the lives of working class people. Thanks. And it's an imperfect system, but many of us have the requisite privilege to show up. Simplifying a bit, the stakeholder process was where we could contribute to the content of the policy itself, and the canvassing was an effort to secure votes and put pressure on council members. The ordinance we ended up passing was very close to what our side was advocating for. What we advocated for was quite ambitious, but it played out such that this final ordinance, like Tyler and Sasha said, is now a model for adoption throughout the state and throughout the nation. Without our voices there, including those from partner organizations, the conversation would have been dominated by the well-represented businesses whose main contribution at the stakeholder meetings was to complain about how the whole process was unfair to them. Right, yeah. I think that they were pushing for 0 hours, but yeah. Thanks to WorkStrong coalition partners like CPPP and like Workers' Defense, DSA's involvement in these meetings required relatively little organizing energy. We just had to show up, but it had an outsized impact on the overall policy. So, on to canvassing. Most of us leading these efforts were pretty new to DSA. We weren't all the seasoned canvassers that we are now. So we just outlined a very basic strategy. We'd host a practice run, learn from that, and then conduct a series of large-scale canvasses in targeted districts. As an aside, geographically divided city council districts gave us a much stronger basis on which to target council members. We've only had such a system in place since 2014. It has its own problems of council members fighting for their slice of the pie at the expense of the city at large, but it's an immense achievement towards overall democratic accountability, and we took full advantage of that. Our practice run was simple enough. We just gathered 24 extremely eager socialists, gave them some lit, and set ourselves forward in a council district where the representative really should have been on board, but wasn't. At that practice run, we collected 99 signatures of residents who were down with paid sick days, down with Medicare for all, and maybe down to join DSA. We also held plenty of extended conversations. This first experience really demonstrated to a lot of us, how simple, effective, and life-affirming it was to just talk to people about real issues and actually engage with just random residents in the city. From there, all we did was expand the scale of our operations. We were really building our organization with this campaign. For our major launch following the pilot canvas, I spent 2 weeks phone banking all 800 Austin DSA members to come out, and it was a great success. The official launch of our paid sick days Medicare for all, or /Medicare for all canvas was the largest event that Austin DSA had ever held. Our greatest challenge for our big launch was lit prep, mainly just the cost. We hadn't produced materials at such a large scale before, and we underestimated how much ink and paper we'd really need to do this. But that was our biggest problem, which is pretty good. The canvas itself could not have run more smoothly. Certainly it's worth considering the choke points in the process on the day of, how much training might be required, how teams and rides will be arranged. But these sorts of considerations are very much dependent on the overall state of your organization, and y'all are a much more mature chapter than we were when we began this campaign. As far as how we solved the lit issue, we just got the hookup from a generous institutional partner. Highly recommend. It's like hundreds of dollars per canvas. It was important to us to make the canvassing effort itself as accessible and welcoming as possible. We brought a bunch of food for the 100 or so attendees, plenty of coffee, that sort of thing. We identified wheelchair accessible turfs beforehand, and we created mobile support roles for people for whom canvassing might be especially challenging or uncomfortable. Once everyone arrived and grabbed a bite, we gave a primer on the campaigns, things that are useful to hear right before you go out and knock on people's doors in case they might have questions. And to that end, we also provided a fact sheet and an FAQ. This is where it gets a bit tricky. You have to find the balance between adequately preparing canvassers and not overwhelming them, both in a figurative sense and just physically with paper and clipboards and all that. And of course, we had everything in 2 languages as far as the literature that we handed out, English and Spanish. Split people up into groups, let them role play for a bit, and then we rolled out. How we chose where to canvass was obviously one of the more important decisions. It kind of covered the political question of which elected officials need to be pressured, but also just how to choose neighborhoods. Someone floated the idea of VAN, or Voter Access Network, but we found that it's generally inadvisable for DSA work, especially for issue campaigns. VAN is how political campaigns target their voters and knock on doors and make phone calls and so on, but it's just a list of people who have voted in previous elections, and so it's kind of inherently reactionary in that sense. And what we're trying to do is reach all these sectors that are unrepresented by people who have already voted. As DSA, both in this campaign and just in general. If you're trying to build a mass working class movement, it's going to involve a lot of people who will not show up on VAN. Instead, we just got one of our badass tech bros to create a simple tool that's freely available that pulls residences from Google Maps and cuts turf. Unless there's some other concern, targeting denser neighborhoods is generally best because it's more efficient getting from one door to the next. And to some extent, you're selecting for those sectors that I've talked about that we're trying to reach anyway. Right, that was it. Ultimately, what matters is that enthusiastic socialists and their allies knock on their neighbors' doors and talk to them about how we're trying to make society better in a way that directly affects them. It's unfortunately incredibly easy to connect with strangers over the woes of the American healthcare system, and that's enough to resonate with anyone from your Bernie bros, those who don't vote, and Trump supporters who agree that America isn't already great. So from here, the operational boundaries of municipal level activism are to a significant extent shaped by higher order regulations, right, that come from the state or the federal government. Texas cities cannot raise the minimum wage, but we can mandate paid sick days. So in Austin, we did, and the best way to build on that success is by keeping it going throughout other cities, building solidarity statewide, and united opposition to the state lawmakers that are out against us. Ledge may not care what a standalone DSA chapter has to say, but in Austin alone, there are over 200,000 workers who will get paid sick days and are going to get significantly more politicized when the state tries to take that away from them. We should be fighting at the local level to get the best we can out of the policies and government officials that we already have, and then also coordinating on as broad a scale as possible to change the rules that govern the rules. Imagine tripling the minimum wage, right? So as y'all pursue paid sick days, I'd encourage you to be in close contact with the other chapters that are working on this, San Antonio, Dallas, and us. Our work is ongoing. We're building a movement. Thank you.
Thank you so much, Ashkan. Next, we will have Dan DeRozier, our co-chair for our state and local working group, to give an update on our electoral work. So, Dan?
Howdy. Can everyone hear me? Can anyone not hear me? Anyway. Thanks for coming. We're really thrilled to have everyone here, and it's really cool to see a room full of activists that are all fired up about healthcare justice. I'm going to touch really briefly on... Hello. I'm going to touch briefly on our chapter and some of the work that we've been doing and the work that we have planned for the future. You know, we're all here to talk about healthcare justice. Healthcare justice unites all of our areas of activism, and it's a clear instantiation of the vision that we have for the world that we want to live in. And ultimately, Houston DSA's chapter work is about building that world, and it's about that vision. Doing so is hard, as I think we all understand. You know, it's not going to be easy to do the work that we're doing and to build the world that we want to live in. But we get there by building a community. We get there by building a community of organizers, like the folks in this room, activists, organizations, left organizations, and workers and regular folks, people who don't necessarily feel heard by the powers that be or by society. We do that by building our capacity as organizers. And the work that we are planning to do over the coming weeks and months and years is all about building that capacity as organizers and, advancing those goals. So, for instance, one of the groups that we've got in Houston DSA is our Medicare for All working group. That's the group that put this event together that we're all enjoying. And a bunch of events that are coming up very soon, including a canvas tomorrow, and monthly canvases from here on out to, go out in the neighborhoods and talk to people, talk to our neighbors, our friends, our fellow workers and citizens and non-citizens and everybody about, this issue. We are organizing all sorts of other forms of outreach, and that includes paid sick leave, and I think we have a lot to say about that coming up. We have our state and local working group, which is handling some of the policy and messaging side of paid sick leave and Medicare for All. Right? It's doing policy research, it's writing messaging, it's registering voters. We have, if you check your program, you'll see some information about an upcoming event that we've got to do a deputy voter registrar training so that we can register people to vote, because registering voters is a key part of what we're trying to do from here on out. But it's not just, those groups, it's everything that we're doing. Our chapter's activities include an eco-socialist working group, feminist socialist working group, Harvey Relief, labor working group, queer and trans working group, religious socialists, veterans working group. And, healthcare justice and the fight for healthcare justice animates the work of all of these groups, and vice versa, that all of these groups, their struggles are all connected, and healthcare is one of those things that connects it. So kind of regardless of the work that's being done, it is advancing this goal. There's plenty of work to be done. One of the things that I really enjoy about being a member of Houston DSA and building the kind of community that we're building is that it really, takes all perspectives, it takes all types of people and all types of skills to build the community that we are trying to build. So that includes everything from having those conversations and knocking on doors. It's straight up organizing. It's writing. It's designing. It's knocking down walls of houses that need muck and gut. Right? It's so many different types of work that really there's kind of something for everybody. And getting involved in it is super fulfilling. And it's doing the work. It's doing the work that we need to do in order to build this world that we want and to achieve healthcare justice. So, for those of you in the room who've already been working with us, I think we can all agree that it's been a blast, and that I think we're all really fired up about what is in store for us over the next months and years. And if you haven't been working with us, we would love to have you. We would love to work with every single one of you. I think that everyone here brings something unique to the table, and that if we all work together, we're gonna win. So thank you.
Thank you, Dan. Next up, we have Timothy Faust. Timothy Faust is a single-payer activist with the Democratic Socialists of America. Over the past year, he has driven 10,000 miles to speak about single-payer to groups of activists, med students, law students, and general assemblies. Over 1,000 people in 27 states so far, targeting 48 states, targeting all 48 continental states by the end of summer 2018. He's pursuing an MPA at NYU's Wagner School of Public Service and hosts Heavy Medical, a podcast about health policy and metal music. His book, Health Justice Now, Single Payer and What Comes Next, will be published by Melville House this fall. Welcome, Tim.
Howdy, y'all. Let me 1 second to get my stuff together. There we go. Y'all hear me? Wonderful. I'll try to play with the mic nicely, but I might kind of move my stuff around. Thank y'all for having me back. Like Nick said, I've been driving around the U.S. talking about single payer to anybody who will listen, but Houston really for me is home. I moved here when I was 17, had my first legal beer here, had my several first 1,000 illegal beers here, have come back whenever I could. And last fall, I was doing orientation for grad school, which was a mistake, when Harvey hit. And I left grad school orientation early, like I'm leaving grad school early, and went home and just hit refresh over and over and over again on reservoir levels. It's really hard to watch your home be destroyed from afar by uncontrollable forces, capitalism and fast motion. And in the months since, I got to watch Houston DSA come together to go out and muck and gut, to extend the basic decency of being both good socialists and also good neighbors to folks who are in need, to go talk to folks afflicted and offer them relief no matter how minor it is. And so I am so enamored with all y'all, and I'm so proud you invited me back to talk about single payer and healthcare, so thank you very much. I'm on this big road trip talking about single payer. We're going to do a Q&A afterward. Please ask Qs that I can A. I love to A Qs, but also I have Qs for y'all to A, if you don't mind. As I travel around, it's really important to understand healthcare is a national fight, but healthcare needs are local. What healthcare looks like inside the loop and beyond 610 and beyond the Beltway is different from what healthcare looks like in Austin or San Antonio or Brownsville or Brooklyn or Pennsylvania or Pittsburgh or Little Rock, Arkansas. And so these fights are local, and as I travel, I want to understand, and I need to understand if I want to do a good job, kind of what we're fighting for from coast to coast and plains to Gulf. I want to carry everyone I talk to in my heart, and there's a lot of folks suffering around the U.S. So please, if there are things you have seen or things you understand that are local, when ways people are suffering, please share them with me. That's important to me. Also, by way of disclosure, in my day job, which I barely go to, I am employed in the insurance industry. Obviously, nothing I say is representative of them, and vice versa. Please consider this my atonement for participating in capitalism. Also, I just drank an entire sugar-free Red Bull and a Starbucks thing with protein, so I'm full of vinegar. I'm going to attempt to keep my language PG because we are in a church gym, the most sacred of all kinds of gyms. But please forgive me if I slip because I'm very, very mad all the time. All right, we all good? All right, ride with me for about half an hour. I'm so sorry about slowing down. I'm really bad at it. I want to start by talking about what we have health finance in America, and what we want instead, and what comes next, what lays beyond that. I want to talk about the relatively benign structural changes that we demand instead. I want to talk about the overwhelming and numbing brutality of for-profit healthcare, and then I want to talk about something bigger, a broader vision of a better world, the moral compulsion of health justice. That sound good? Wonderful. So I want to start off by confirming something you probably already feel in your bones. You're being pushed around. You're being screwed. And the method by which you are being screwed, or the severity or complexity or the artfulness of the cover-up varies from person to person, but fundamentally, we have created a world in which you are made sick and then punished for being sick so that somebody else can make a huge profit. Let's talk about why. In the U.S., by and large, the costs of receiving health care are much, much more than any individual person can afford by themselves. But not a lot of folks need health care in a given year. In a given year, 50% of all health care costs come from 5% of the population. 80% of all health care costs come from 20% of the population. And that population is fungible, right? It moves around. Maybe some years you have a car accident or a cancer scare or trauma, and other years you don't. So costs move around, but when they hit you real hard. And so if everybody had to pay for all their own medical costs out of pocket, eventually millions of folks would go into crushing debt and medical bankruptcy. That's not a guess, that's history, because out-of-pocket used to be the only way we paid for healthcare costs until a bunch of socialists, a bunch of unionists, and a bunch of healthcare professionals got together in the 1880s and insisted that was immoral, and we shifted eventually to a new payer model, the idea of insurance. Now, insurers are organizations, or in the U.S., companies that receive revenue by charging you monthly premiums. When someone gets sick, insurers spend the money they collect from everybody to pay off a portion of those healthcare costs, plus, of course, keep a profit for themselves. And so the more revenue an insurer receives from customers, or realistically, the more subsidy it receives from public money, the wider those costs are spread, and the lower an insurer's per person cost, because only a few folks are getting sick. That's called a risk pool. But if an insurer has too many sick people, like, for example, if they get just one unexpected person with hemophilia, whose care can cost up to $1 million a year, those per-person costs really increase. And so to compensate, it increases premiums. And when premiums go up, customers drop out because they can't afford them, except, of course, if they can't afford not to afford them because they're sick, so they stay on board. So because they're sick, per-person costs keep going up, so premiums keep going up, and it builds this big, stupid, vicious cycle. Thus, an insurer really, at the end of the day, wants as large and as healthy a risk pool as possible, or it wants to find ways to kick out sick customers or coerce them into leaving. Maybe it drops coverage for drugs that sick people need, or cuts off access to providers or facilities that a lot of sick folks go to. Thus, an insurance company really has one job. It's to make sick people, as much as it can, somebody else's problem. That's what we mean when we say that we live in a world in which healthcare is a commodity, right? Because future's on your heart and future's on your lungs, and your chance of getting diabetes and whether or not your Mima's glaucoma gets better or worse before age 65, and God permitting, she goes on Medicare, are speculated about and fiddled with and bought and sold for profit by private companies. And this fragmented, commodified healthcare model views healthcare as a transaction instead of a relationship between a person, their body, their community, and their doctors. That's perverted. We have mistaken the profit motives of insurers for healthcare. And over time, we've delegated the responsibility of providing insurance to employers, but that's messed up too, because that results in a status quo of total employer domination, in which your access to things like contraception or blood transfusion or hormone therapies are determined by the whims of your employer. But if you aren't lucky enough to have an employer, if you lack the so-called better skills to get one of the so-called better jobs, you're just left behind. And so the people who profit from the commodification of our bodies have decided it is acceptable to shackle the well-being of children to whether or not their parents were lucky enough to have gone back in time 40 years, learned to code, and found a benevolent employer. Welcome to the hell world of America 2018. Now, of course, it gets worse. Much too early in the talk for things not to get worse, because the costs of health care keep increasing. And they increase much, much faster than inflation. Now, part of these costs increases are for good reasons. Costs have been rising since we first began recording them back in the 1880s. Now, part of that's because more folks are living longer and longer with chronic conditions. Things like diabetes or heart attacks or cancer aren't the immediate death sentence as they were even 2 or 3 generations ago. So we spend more money to take care of more people longer. Fantastic. But most of these cost increases are because hospital CEOs and pharmaceutical companies, close personal friend Martin Shkreli, keep finding more and more ways to charge more and more money for the same services or the same drugs, or rack up fees for unnecessary services, and no private insurer can really stop them. Here's how that shakes out. In the US, the average inpatient procedure costs 40% more than the exact same procedure performed the exact same way, except when performed in France. Or take, for example, MRIs. Y'all know MRIs? MRIs are just big, fancy computers that print money. And in the US, an MRI procedure costs 5 times more than the exact same machine performing the exact same procedure in Australia. But most egregiously, consider the relationship between primary care and hospitals. Primary care is things like checkups, basic medications, the kind of familiar, intimate health care you get from your family physician. It's high volume, it's pretty low margin, and generally not super profitable. But now conversely, a hospital gets paid an average of $2,000 a night for an inpatient stay. So we witness a thing called Romer's Law, which is that hospitals will change their admission policies to ensure that every hospital bed that is built is filled, regardless of actual need in the community. So if you're a hospital CEO, it makes a hell of a lot more sense to push folks into inpatient admission instead of wasting your time letting them get cheap primary care outside your hospital system. Now, of course, this means that diseases will be caught late if they're caught at all, and more folks will get sicker and sicker and more expensive to treat, but at the end of the day, the hospital's still getting paid, and the specialists are still getting paid, so everything's great. What's the result of that? 58 million Americans without access to primary care. 28 million of them live in the South. In Texas, 24% of people don't have access to primary care at all. So, as you can see, there are 2 fundamental truths to American health care. One, if you're a payer, like an insurance company, it's just not profitable to insure people who are sick. 2, if you're a provider, like a hospital or a pharma company, an equipment manufacturer, it is extremely profitable to charge sick folks as much as possible, as late as possible, as long as someone's footing the bill. And so upon these jagged rocks, we've built this big, stupid church of American health care, in which the body is valued solely as a source of profit. Now, this whole situation scares the bejesus out of everybody involved, right? Particularly payers. Payers are interested in finding ways to mitigate rising costs. Sometimes that means just refusing to pay for claims outright. You've all heard those horror stories. Maybe they've happened to you or someone you love. Before the Affordable Care Act, it meant that payers would often just refuse to cover people who were likely to get sick. You all know the phrase, pre-existing conditions. But this still wasn't enough to bring costs down. So we all got together, everybody in America, back in the 1970s, and invented the idea of consumer-driven healthcare. It's the idea that you should make consumers, which is just a fancy libertarian way of saying people, pay more for the costs of their own healthcare, right? Because once folks are on the hook for their own costs, that'll turn them into smart shoppers somehow. And through the power of the free market or whatever, they'll shop around and not get unnecessary or expensive care and find the cheapest ED in town if they get hit by a car and yelp their surgeons. And all of this somehow together will drive prices down. Not silly, we've just internalized the language of the oppressor. And all this builds an atomized, unambitious, and honestly pretty lonely worldview of what healthcare is and what healthcare can and should be. It treats being sick or being poor, or being able to get pregnant as a character flaw. And that means if you get hit by a car, or you give birth to a premature baby, or you get rabies, you're on the hook for your own costs. And if those costs force you into a lifetime of crushing debt or medical bankruptcy so that a hospital, a pharma company, or your insurer can turn a profit, well, tough. It was your responsibility, because health, we're told, is a matter of personal accountability. That's just the breaks. Consumer-driven healthcare, then, only serves the folks who seek to extract profit from our bodies. And you know what's worse than that? It doesn't even work. No, people who are forced to pay for healthcare costs they can't afford just don't seek healthcare. And I don't mean emergency care or catastrophic care. No, they don't seek primary care or preventive care. They ignore that rash, try not to look at that tumor, think away that chest pain. Because we demand people bear the burden of healthcare costs they cannot afford, they turn their bodies into ticking time bombs until they have a heart attack at their jobs and leave their kids behind. That sucks. So what do? Right? How do you square the rampant increase in healthcare costs with the fact that it's just not profitable to insure sick people? Well, if you're the Democrats, you could collaborate with the Heritage Foundation to offer us the Affordable Care Act, which is, at its core, the massive subsidization of private industry with public money. I think it's a bummer, actually. The ACA is a big plaintive wail, a big bargain, right? Please, 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 how many billions of dollars do we gotta give you so you stop getting sick people off their insurance plans? Now, the ACA, of course, had its successes. First and foremost among them, the expansion of Medicaid. In places where Medicaid was expanded, we saw a 6.1% reduction in the mortality rate. That's 11.1% among communities of color. Now, we understand why. These are folks that have been systematically, if not violently, denied access to health care in the first place. So even the relatively meager expansion of Medicaid does a hell of a lot to help folks seek essential care when they need to. But at the end of the day, it's not enough. Costs keep increasing, quality of care stagnates for the most vulnerable among us, and 28 million people are still uninsured. The ACA has failed in its pursuit of health justice. And so, here's the table stakes. Among so-called developed countries, America is the most dangerous place to be sick. Among peer countries, America is the most dangerous place to be black, the most dangerous place to be pregnant, with the highest maternal mortality rate of any first world nation, of which 60% are entirely preventable. It is the most dangerous place to be a child, the most dangerous place to be a woman, the most dangerous place to be gay, the most dangerous place to be old, and one of the most dangerous places to be disabled. Last year, life expectancy at birth fell for the first time in almost 30 years by a tenth of a year. Across the 4 million people born last year, that's a theft of 400,000 years. But a funny thing happens when you look at this data more closely. You know what I'm going to say. It is woven into the American fabric. When you look at the data more closely, you realize all this danger only exists if you're poor. Because rich people are exempted from all these problems. Men born in the wealthiest fifth of Americans get to live 15 years longer than men born in the poorest fifth. Among women, that gap is only 10 years. This is war. This is the terrible secret of American healthcare. They are killing us and robbing our corpses. Enough. This big, stupid, multi-payer, profit-driven Rube Goldberg machine of American healthcare is failing us today, and left unchecked will collapse tomorrow. That is incontrovertible. So instead, we demand something different. We demand a federal, universal, single payer. Oh, it gets better. Single payer, pretty simple concept. Setting a bunch of individual insurers with a bunch of fragmented customer bases, each seeking to pass the buck and avoid taking care of unprofitable sick people, heaven forbid. We have one publicly owned, publicly funded insurer with a legislated mandate to cover in full all care for all people. Now, that phrase, all care for all people is important. Not Medicare as it exists today, which still has co-pays and deductibles and cost sharing, but a comprehensive program, merge parts A, B, and D of Medicare, throw C at the window, it's just legalized fraud, and offer comprehensive coverage for all people in America, including long-term care, that is free at the point of service with no cost sharing. Here's how it looks in practice. Right now, you want to go to the hospital or you call a clinic to schedule an appointment, and the first thing you're asked, often even before what your name is who your insurer is. That's because providers, and I think reasonably, are afraid of providing services, especially those that are expensive to provide, without guarantee of reimbursement or guarantee of getting paid. So before we can be considered for care, we must answer, well, on whose dime? We've just constructed this big brass squid, a huge, invulnerable, and dumb monster that hates us and who flaps around, getting between us and our providers. And this huge, dumb squid forces doctors to spend half their day filling out forms to justify their work to payers, and it forces nurses to spend a quarter of their time adjudicating claims and seeking authorization for service from insurers. Under a single-payer system, we starve and replace that squid. The question of who's paying for it is answered. It's Medicare. So we preserve and protect and nourish and strengthen the provider-patient relationship by eliminating the question altogether of how can the patient afford this. That's great because everybody benefits when accessing care is free and easy. Delivering care, right, being a doctor, being a nurse, being a social worker, that's complicated. Bodies are big bags of goo we barely understand that hurt all the time, and offering any relief is really complicated, but paying for it isn't. Paying for it is simple. In fact, we're already paying for it. We're just forced to spend that money really, really stupidly. American public money right now pays for 2/3 of all healthcare costs in the U.S. Half of that 2/3 is actual Medicare, Medicaid, or VA spending. Other half of that 2/3 is just government subsidies to private companies. The remaining third is out-of-pocket costs, an additional tax you pay to insurers, from premiums, deductibles, and copays. And so the goal is to reallocate this spending, take care of everybody long term. Our current model will see an increase by $1 trillion in the next decade of total healthcare spending. At the very, very least, a single-payer program keeps our current national spending flat while relieving folks of healthcare costs and spending more wisely to take care of more people. I think the Sanders bill, which isn't perfect, but it's getting there, sees out-of-pocket costs for a family of 4 making $40K a year go from $5,300 a year to $470 a year. Well, we know that Medicare negotiates much, much better prices for care nationwide because it bargains on behalf of 44 million people instead of a few hundo-thundo in a given county or a few thousand in a given city. So you scale that idea up. By negotiating on behalf of 300 million people, a single payer can set fair prices for care while developing the models necessary to incentivize good behavior and compensate providers justly. But even before that happens, we free up all the money associated with administrative costs and profit in the private insurance market. This optimization, or in their terms, this innovation, opens up, in a conservative estimate, an additional $370 billion a year, which is a pretty big chunk of change. So what do we do with it? Well, we use it to improve everyone's standard of living. We build or reopen primary care clinics in rural areas. We fund community health centers in poor neighborhoods, and most importantly, we return the money to the people who do the work. Take, for example, y'all know home health aides? I have like a sick parent, a sick kid, a sick friend. A person can receive care in the hospital, which is great, but sometimes a person doesn't need inpatient hospital care, right? Maybe they just need medication management or physical therapy, so they can receive that care at home. That's great. Again, being inpatient, $2,000 a night. Home is where your computer lives. Home is where your dog lives. Home is where your friends and partners are. So you can receive that same level of care at home. Fantastic. It's billed at an average of $150 per visit. So everybody benefits. More humane care, and we save money. Everybody benefits except, of course, for the home health aides themselves. Because for this essential care, they are paid an average of $11 an hour nationwide, and much, much less in Texas. So we can allocate this money that we save to do what the private market won't, which is pay fair wages for essential care that helps everyone. Now, we do this because it's the right thing to do, sure, but also because we have to. Now, think about this for a second, right? Medicare is a program in which hospitals are penalized if someone's readmitted to surgery within 6 weeks of a surgery, right? So if I'm a Medicare patient and I have a heart attack and I go to the hospital and get a pacemaker and then I have another heart attack in 2 weeks, Medicare will pay the hospital less in an attempt to get them to keep people from readmitting. There are problems with that, but it prompts the question, who is it that keeps people from getting readmitted to the hospital after cardiac failure? Is it the cardiologist or the heart surgeon? Is it the pacemaker itself or the expensive data package that lets nerds monitor pacemaker metrics? No, those are the folks that get paid the most and who can charge the most for their services. The people who make a difference are the social worker, the nutritionist, the nurse, the patient advocate, the folks who educate and persuade and comfort and soothe. And so when one hospital in Little Rock, which is the diabetes capital of the US, invested in those people, hiring a few social workers and a few nurses to take patients in after heart surgery to guide them towards relatively cheap exercise and cooking classes in the social environment 3 times a week, they saw their readmission rates fall from 26 to 4%. Despite what app companies insist, there are no apps that bring about better health. A how to survive on $4 a meal cookbook doesn't do shit for folks that only have $4 a meal. Programs that penalize you for going to the ED at the wrong time don't do anything to make you healthier outside the hospital, and thus, unsurprisingly, it is non-diagnostic, extra-clinical care. It is compassionate labor that drives virtually all actual improvements in population health. Social workers, patient advocates, nurses, these are the folks chronically unrecognized and undervalued, but they're the only folks who make a difference in population health. And so there's a, yeah, hell yeah, nurses rule. And so, of course, this is America, right? There's a certain irony that in the face of automation and exploiting labor overseas, it's these jobs of compassionate labor that are the fastest growing jobs in America. But no private actor values them, right? Because they don't have to. So we have a paradox of more and more folks performing essential labor, home health aides, social workers, nurses, etc., who are thus paid less and less and less. Because in a multi-payer private model, nobody's invested in paying them more, and they never will be. Right now, your private insurer only bears the costs of you receiving care while they're insuring you. Because you're going to change insurers in the future, and God permitting, go on Medicare eventually, they don't feel any pressure to keep you healthy in the distant future. Right? Instead, we all do, because we all suffer when our friends and family get sick, and our public money is allocated to care for our communities in times of crisis. This isn't a complex idea, right? I think you all know this already. For example, you know that if your window is broken and it's the winter, the cold gets in. And if the cold gets in, you're probably going to get sick. And if you get sick or if your kid gets sick, you got to go to the doctor. And if the local clinic was shut down or it's booked solid, you got to go to the hospital. And if the hospital is far away or you don't have a car, you got to take the bus. And if you got to take the bus, you have to spend all goddamn day dealing with the bus system. And if you're going to spend all day dealing with the bus, you can't go to work. And if you can't go to work, you can't afford to fix the window that caused the problem in the first place. And so the answer isn't to fork over a pile of cash every time you go to the doctor. The answer begins with fixing the goddamn window. But there are no private actors in the American model who will bear responsibility for fixing this on their own. The insurance industry is incapable of addressing the foundational problems of healthcare, of fixing broken windows, of reopening the 18 rural clinics in Texas that have shut down since 2013, of fixing the ruptured PVC septic systems in rural South Carolina that have brought hookworm back to the state in the exact same way that a billionaire is incapable of lessening income inequality, or a cop is incapable of shrinking the prison industrial complex. They cannot fix the injustice because they have been constructed by and within the injustice. They cannot solve these problems because they existentially cannot conceive of them as problems in the first place. But we do. And so it makes perfect sense that the same actor who suffers when folks don't get care, which is all of us united, represented by our federal government, should be the actor who pays for that care in the first place. Because once the federal actor bears the costs of providing care and the risks and costs of not providing care, it can finally be used as a tool for realizing health justice. If your people are getting sick and dying because they don't have a place to live, or the places to live are unsafe, I'm thinking of the Grenfell Towers in the UK or Ghost Ship in Oakland, then housing is healthcare. And you must build free or affordable housing to bring healthcare costs down. If people are getting sick and dying because they don't have access to healthy food to eat, it's not profitable to sell a poor person vegetables, and so they're getting diabetes or comorbidities like cardiac failure, then food is healthcare. And you must provide people with affordable or free food options and the time, space, and materials with which to prepare them to bring healthcare costs down. If your population is getting sick and dying, they don't have access to needle exchange programs, therapy, or counseling, then rehabilitation is healthcare. And not our current myopic focus on end-of-life palliative care only, but the full social structures required to help people handle addiction, or perhaps not pursue it in the first place. That's how you bring healthcare costs down, because single payer is not the goal. Single payer is only a tool. Health justice is the goal. And when we fight for health justice, we all fight side by side, because economic justice is health justice. Environmental justice is health justice. Reproductive justice is health justice. And justice for black lives, justice for brown lives, justice for trans lives, justice for lives of immigrants, and the well-being of all people, regardless of age, gender, race, or creed, that's health justice. We have inherited a world in which your permission to receive health care, capital's allowance, you can be safe in your own body, is dependent upon how much an insurer can extract a profit from you. And thus, we have permitted in our country utter desolation. Without our consent, we have been forced to participate in the condemnation, criminalization, and abandonment of people in need. People with disabilities got to spend tens of hours a week pleading with insurance companies for a chance to maybe go on a waiting list to receive the bare minimum of care required to keep them alive, if they're lucky. The unlucky ones got to plead with Medicaid or Social Security for maybe considering compensating their parents, partners, or friends a whopping $1,000 a month for taking care of them full time. Elsewhere in America, the opioid epidemic, an epidemic whose vector is capitalism itself, was originally manufactured as a patent extension ploy with a massive marketing campaign, now kills 180 people a day. And those it doesn't kill are written off as criminals, because only criminals are addicts, and so they're untouchable and left to rot and thrown in jail as their children cry their names. In life, it is poor and uninsured people who are used to test the drugs that are then turned around and sold to the wealthy and insured people. And that servitude continues in death, because it is the organs and bodies of the poor and uninsured that are ripped and sold as transplants to the insured. There is no end to the body horror of capitalism. There is no line too far for the commodification of the body. America has cheered the privatized slashing and burning of social structures, and then has the audacity to punish people for struggling. When people are in need, we waste time, effort, and money means testing, separating the worthy from the unworthy among those who need help, and then stigmatizing them instead of guaranteeing the basic decency of health equity. This is cyclical. This has happened forever. It will continue to happen as long as we tolerate, even in whispers, the idea that the body is a commodity. And for systematically marginalized people, sick people, homeless people, people struggling with addiction, people with disabilities, poor people, pregnant people, trans people, women, and people of color, well, this is America. When there is no way for the medical industrial complex to value their bodies, then there's always the private prison system ready to receive them for profit. And so single payer is not the revolution. It is our first counterattack in a war that is already waged against us, by which subsequent counterattacks are made possible. It is not only the only reasonable method of controlling healthcare costs while guaranteeing universal coverage. It is the tool by which we force ourselves and force the state to reckon with the racist, sexist, and classist provision of healthcare in this country, and to begin to strive toward relief. Yeah, hell yeah. It is the beginning of a prayer, the beginning of the articulation of health justice. My friends, single payer is moral. Single payer is necessary. And single payer is achievable. Solidarity now, solidarity forever. That was my monster break. Oof. Let go on that monster, man. I want to talk really briefly about paid sick, what we all can do, right? Right now, we all stand on the shoulders of the labor movement, of hundreds of thousands of nurses, of tens of thousands of doctors who have demanded a clear and focused vision of the future, that insurance is not healthcare, and healthcare is something a just nation affords all its people. And so we have a job. We must build the popular movement which begins by demanding single payer from our government and continues to demand health justice in our nation. And when folks tell us we're bringing about creeping socialism, that we're rejecting the American capitalist way of life, we say, yeah, duh, and keep on fighting. How do we do that? We do that shoulder to shoulder, right? Realistically, you and I together can demand single payer morning, noon, and night from right now until 2020, and that's great, and I will do that, but it won't provide material relief to folks who are suffering now. But luckily for us, this is not an either-or option, right? The idea of health justice affords us the understanding that there's a continuous spectrum of demands, and unlike liberal, try a little bit and give up incrementalism, successes at any point along that spectrum, which offer material benefits to folks now, make success downstream more inevitable. Right? Now, none of us can really guess the health needs of folks around us. The stakes of the single-payer fight are much, much different if you're someone that needs to spend dozens of hours a week trying to get basic care for your needs, or if you've been denied care altogether. And thus, it is our obligation to be good socialists and good neighbors and extend the basic decency of showing up, of going to folks around us, listening, asking questions, listening again, finding common ground, and putting our shoulders to the wheel. And so the ways DSA locals and more around the country are taking on this fight have been pretty cool. In Maine, the Maine People's Alliance fought for and won Medicaid expansion. Local DSA chapters in Tennessee, like in Nashville, are fighting to keep rural hospitals open. In Burlington, they're organizing for statewide primary care. In Cincinnati, they fought for and won a needle exchange, which extremely kicks ass. In other places, DSA locals are fighting for relief from predatory housing practices, like in DC or SF. And there's also the mass movement of teacher strikes, like in West Virginia, in which insurance played a critical role in labor grievances. But most exciting to me, and not just because Austin DSA is here, most exciting to me is what's happening in Austin DSA, what they fought for and won earlier this year, and what I believe y'all might take up the mantle for, which is paid sick leave. Workers' Defense Project covered it pretty well. 70% of low-wage workers in Texas don't have any paid sick time at all, which is super messed up. It's one, and two, it's a health hazard. If you can't take care of yourself or your kids, or you need time to get an abortion because we have a 24-hour waiting period, or you need to seek help with DVSA issues, or you need to move, you're denied access to care, you're denied access to time. And so we must fight for and win it so resoundingly across the state that not even Greg Abbott can pry it from our grasp. Because it's an act of health justice. We can win paid sick today so that tomorrow those people we help will fight with us to win Medicaid expansion. That's exactly how they want it in Maine, and through this work we can win single payer in America. We build solidarity today so that tomorrow we build and win power. And we can insist upon our vision of health justice as a guiding light through every step of the process. This is a fight we will win because we must. The tide of history, luckily, is in our favor. Medicare for all polls at 64% in favor nationwide. This is not a radical proposition among the folks it affects. My friends, single payer is inevitable once we make it inevitable. Paid sick leave is inevitable once we make it inevitable. And health justice is inevitable once we make it inevitable. And thus I am so, so proud to stand shoulder to shoulder with y'all. That's it for real. Solidarity now, solidarity forever. Solidarity, y'all.
So I was thinking I could ask a few questions from the people up here, and then we can open it up to Q&A from the audience. Now, we've heard a lot of stuff today about a lot of different topics, so why don't we just go to a simple, basic question. What is it that you want people to walk away with after hearing all this? What's the number one thing that you want them to know, to be thinking about?
We're going to win.
Yeah, 40,000 people a year, 30 to 40,000 die from lack of coverage alone. It's wholly unnecessary for all the reasons that Tim outlined. We are going to win. We're going to take care of that.
So similarly, we're going to win, but we're going to win because we're going to be smart, coordinated, and strategic, and set a goal and work together towards that goal.
All causes are united. The body is the source of the crisis, is like the location of the crisis, and so things like housing and food and paid sick are all essential building blocks of the overall thing. And there is nothing scarier to those that set policy than an organized, progressive organization that calls their shot and then gets it. So by winning paid sick here, we open up the door to win more things down the road with the folks we help, and that kicks ass.
So it sounds like we're going to win.
Yes.
That's good to know, but it seems like one of the big challenges is that the people who would really benefit from this stuff are the people who don't have power. They're poor, they're working, they're spread out, they're not united. How do you reach people, and how do you get them engaged?
How do we get people engaged? Events like this, We have to go out in the community, though. That's a lot about what we're talking about today, is that we have to be out there. We can't wait for people to come to us because they're out there doing their jobs. They're out there dealing with calling insurance companies because they won't cover the medical care that they need. They're out there not having insurance and they're sick and they don't feel good. So we're going to have to go out there, we're going to have to talk to them, we're going to have to educate our neighbors, and we're going to have to tell them that it's okay to demand Medicare for all.
Right, so a lot of us have all the privilege in the world to spend our time at these things and reach out to people, and we need to use that to connect with everyone else about issues that directly affect their lives. That's how you get people engaged, and that's what we're trying to do.
So for workers' defense, I think we think pretty intently about this issue. And our organization, we organize people and our people at their workplaces and people where they are. And ultimately for our organization, one of our goals is to make all of our campaigns be something that's reflective of what they want, and then ultimately use them to uplift their stories. And so our members have a say in the work that we're doing and the way that we do our work. Ultimately, this is Saturday, far away from our members, but usually in these spaces, we prefer to elevate our members' voices, and so we're doing it by going to them where they are, letting them drive the campaign, and letting their voice be the voice of the campaign.
Everyone got it right. I think the goal is not to proselytize, but to learn. If you believe that people are good and deserve good things, which I do, and that this is a policy which reflects the innate goodness of people, then extending to them the idea that we can join together and do the fight and learn from each other is how you make a difference, how you engage folks in. So long as you permit the idea that other folks that are suffering in ways that you don't see or that are invisible to you have a lot to teach you, you can build a good coalition of folks that work together to do good things. I know a dude who canvasses farmers in West Tennessee and East Arkansas. He's in his car, drives around, talks to folks, and that's exactly what he does. He believes in the fight for their Medicaid expansion and single payer, and so he goes to folks and say, they commiserate. Are you being screwed over by your healthcare situation, by health finance? If so, how? What do you want? What do you fear? Is this a thing that appeals to you? How can I help? And then they come back, and they come to meetings, and they drive hours to come to Nashville or Memphis and join a town hall or join in actions. Go to folks with an open mind, go to learn, go to do the work, and people will come meet you.
It seems there's also another flip side to that if you want to get into power, there are people who are already there. Some of them who feel like they're on your side, but when you say, we need universal health care, we need paid sick time, they say, well, that's too much, not too fast, go a little slower. And I wonder, in your time as activists and doing activism, do you find that there are ways to reach people, to change their minds, to pull them onto your side?
I guess I find myself unconcerned with convincing current leadership to make the leap to Medicare for all. I think that we have to ask for what we want, because we are never ever going to get what we want if we ask for half as much. So for that reason, I think we have to make a demand. We have to say we want all of it. We don't want co-pays. We don't want paid sick time for only some people. We have to say, this is what we need. We elected you, you represent us, and we need healthcare justice now.
We don't want the crumbs, we want the whole loaf.
Can I use that? Yeah. Right, yeah, exactly. You have to ask, the role of outside activists, right, is to be wholly uncompromising. We are fighting from a very pure position. Ask for the world, take what you get, and keep demanding more.
I think everybody's right? It's going in and being a good activist and fighting for what you believe in with the people that are currently in power. But ultimately, and this is, stealing the phrase from my former employer, it's not about creating good ways and electing people we can lobby. It's about electing people we don't have to lobby. And so ultimately, it's organizing everyone to elect champions of these policies versus people we have to go and ultimately convince to be for us on these policies.
You handle electeds like the knuckle tattoos in Night of the Hunter, through fear and love. They love you because you built them up and you carried them forward, and they fear you because you've built a power structure which can punish them for not doing what they need to do.
All right, now I want to take some questions from the audience. Before we start this, I want everyone to know that a question is a sentence that ends in a question mark. Okay? All right. Now, raise your hands. I'll point at people. And then I will repeat your question over the microphone, and then we'll get some answers. So your hand was up pretty quickly. So what is it?
What is the root cause of the problems that we're dealing with, causing all this disparity in medical care, disparity in the time off necessary, disparity in helping the people? I think I want to hit Tim first.
All right, so what is the root cause of all these problems that we're talking about and all this disparity?
We all want this one so badly.
Right.
Can we say it in unison?
Yeah.
It's capitalism.
What is that? When we say capitalism, what do we mean for those of us who...
Capitalism works.
Oh! I disagree, but I don't want to get into an argument. I will say that I'm really interested, for example, in the opioid epidemic, right? Because it is an epidemic, but epidemics have vectors. Diseases have vectors. The vector of the opioid epidemic is capitalism. Just like we have created a structure in which we drain communities, we rob them of resources. It was internal colonialism of urban areas in the 60s and 70s, taking money and capital from people of color and giving them nothing in return. And now it's taking capital and resources from rural areas that have deindustrialized, giving them nothing in return. We introduce medicines and therapies that are essential for some people, but we spread them so widely that they're widely available, and we punish folks for needing them. We punish people for turning to selling drugs when there are no other jobs available, and we punish them when they use those drugs or when they battle addiction. When somebody is battling addiction, we put them in jail because that's the way you make money off of them, because it's not profitable to take care of people that are sick, but it's very profitable to charge the state to put them in prison. All these things are born from a profit motive, not an assessment of what do the people need, but what do the people that make money off of this need. It is innately woven into the problem of health inequality in America. There is no, you can either put together a bunch of individual theories that say, oh, it's this particular drug, and this particular patent, and this particular policy that caused this problem, or you can look at an underlying ideological cause, which is capitalism itself. So I'm not being reductive, I'm being very specific in diagnosing the problem when I say that the cause of health inequity in America is and will forever be capitalism.
You can all answer.
All right, so I will say I'm vastly underqualified to answer the question, what is the root cause of all of our problems? I mean, there are a number of different things to point to, and the reality, if I knew the root cause, right, I'd be making a lot more money. I wouldn't be sitting here, and honestly, if I knew the root cause of all our problems, I'd be making a lot of money. I wouldn't be sitting here. I shouldn't be sitting here. I'd be working on figuring them out. But I think ultimately, the thing that we have to work on is addressing what are the many things that are the root cause, and addressing one of the main factors, which is access to power and access to decision making. Ultimately, the people make decisions, or the people with means to make the decisions, and we should all be advocating for people that either don't have the means to have influence, or they don't have the platform that exists to have influence. And I think that's working towards what the root cause of the problem, be it capitalism or human greed, or just that we're all inherently flawed, and the loudest people that are wrong get to make the decisions. It's about uplifting all voices and working towards that end.
For the common good.
The other issue besides, the root cause of the problem is capitalism, but one of the factors that come into that is that capitalism keeps us divided, it keeps us busy, it keeps us hungry and insecure. And because of that, we lack something that the money of our population have, and that's organization. And that's something that we can actually take out and grasp for ourselves. So what we have to do is we have to be organized. We have to be a population that's organized. That way that we can fight for what we deserve, because they are organizing against us, they are organizing to make money off of us, and until we organize and stand up, we're not gonna win.
Given that this is a question kind of about the dynamics in some of these policies at the Austin level, your city council has a bit of a different dynamic than our city council does when it comes to a wide variety of issues. I was wondering if you could speak to the role that dynamic played in getting sick leave, or what barriers you had to overcome, or
those who couldn't hear, the question was about the dynamics of the Austin City Council.
So it's not technically nonpartisan, but we have 10 people, including the mayor, who are basically Democrats and 1 Republican. We never really sought to get the Republicans' vote, but you know, it's kind of interesting for people who are first getting involved to see like, oh, they're all Democrats, they'll be for this. And it doesn't work that way. Just as far as how the dynamics worked out, I mean, like we looked at the people who really should have been on board in terms of what they claim to represent and what they say their values are. And like I said, we targeted their districts. I'd be interested to hear about the dynamics of Houston City Council and how that plays out. I'll let you go.
So I think in addition to partisan dynamics, whatever they may be, and the differences that there are between Austin and Houston, there are some real structural dynamics that are different, right? In the city of Austin, you have council members that can introduce ordinances, right? The how an ordinance becomes a law process is different in both of these cities. In the city of Houston, you have a strong mayor form of government, so ultimately you need to get all council members on board, but there's one that you have to get on board first in order for this to even become part of something that's in consideration. And the other structural differences that exist, Austin has an input process that is a little more technologically advanced than the city of Houston. But ultimately, we're a bigger city, and the big dynamic as we go off of talking about capitalism and we look at who the opponents of these ordinances are, you have a Chamber of Commerce in Austin, but the amount of power that they have in the city compared with the amount of power that, say, someone like the Greater Houston Partnership has is vastly different. And so you're looking at the people that are going to be opponents of this, not just on council, that there's an inherent difference between the two cities, but the opponents are more well-funded, more well-connected, and so there are a lot of challenges, some structural and some just the dynamic differences between the council members themselves and the voices in the room.
Just a note, everyone ended up voting for it except 2 people. So.
All right, well, I think we've got time for one more question. Does anyone out there want to close us out? In the back.
Hi, I just had a question about informal caregivers and formal caregivers that get extremely low pay, and I wonder if there's what Medicare for All says about this, or how y'all deal with the informal caregiver role. Most of them make minimum wage for older people that are unpaid and caregivers, and I wonder what y'all think about the supports they need, or this is also what you take into consideration when you're thinking about it.
All right, well, the question was about Medicare for All and how it would cover informal caregivers in contrast to formal caregivers, because informal caregivers often aren't compensated for the work that they do. We'll start on this end.
I can say I don't know where that would fall under Medicare for All, but I do have a strong belief, and I believe that most of my comrades in DSA would agree that domestic labor is labor, and all labor should be paid.
Wages for housework, right? I mean, I don't know how much this can't really covered under Medicare for All. We got to keep pushing. And,
Yeah, and just building off what people say, and the fact that achieving these goals are built around everyone working together. And one of the things that everyone believes is that people should be paid fairly for their work. And like I said before, right, Medicare for All is the tool through which that change happens. And it might not be something that's actually addressed in an actual bill.
Forgive me for a long answer. It is a parallel fight that is part and parcel of health justice, but not necessarily within like the health finance structure itself. Health outcomes, population health outcomes, are driven almost entirely by compassionate labor. What Silvia Federici called feminized labor, but I think is more aptly described as compassionate labor, right? We work with nurturing and soothing, whether that's informally, a parent to a child, or formally, a formal caregiver to a sick person. All outcomes come from those relationships, and we have systematically devalued them, right? We pay the specialist over the millions of dollars in some cases, and we pay the informal caregiver or the formal caregiver beans relatively. A single payer is forced to consider long-term health effects. caregivers, right? It is unsustainable to continue forcing folks into specialty care or to continue like pushing money into specialty care, because that comes at the expense of primary care, and it comes at the expense, more importantly, of social workers and nurses and other kinds of caregivers. I think the broader argument for paying other kinds of labor, for paying informal compassionate labor or not in a formal work structure, is a parallel fight, but one that is not resolved within single payer. But I think the single payer, or if you want to gun for that, an American national health system, which is not necessarily in and of itself more redistributive than a single payer. I think it's a parallel fight. This is the only tool we have or could have that would force it into being, I think. As long as you permit the determination of who receives money for care to private payers, they will never pay informal caregivers because they never have. They can kind of bank on people feeling obligated to care for folks because they love them or because it's the right thing to do, and thus not pay them anything approaching a fair wage. I think a single payer, because it is forced to consider long-term population health, is a tool for which you can begin agitating and building the pressure to consider what is care, what is labor, and paying ultimately, I think, a goal of wages for housework. It is a parallel fight. I think these things are nested, like Matryoshka nesting dolls. I do not think it is necessarily within the finance model, but I think it's hand in hand with it. Does that kind of answer your question? Yes. Cool.
Well, I want to thank everyone for coming. Thank you, Tim, for that answer.
Hell yeah.
And thank you for everyone who spoke today. Thank you for our photographers, our videographers, and thank you all for showing up to learn about this. I'm sure that some of our people will be standing around afterwards to take your questions in person. And enjoy your Saturday.
So I really hope that you've been inspired by what you've heard today, and I hope that you've learned something that you didn't already know. And I also kind of hope that some of what you heard today made you really mad, and I hope that you're ready to do something about it. I can't hold this at the same time. So anyway, you know what we already have, right? We already have a plan that doesn't work. And so today we've shown you a vision of what could be and what we deserve, and we hope that you're ready to demand it. So we have a couple of things. Everyone here got a red pledge card. Anybody get one? All right. So I'd like to see a show of hands right now. Who is already a member of Houston DSA? It's beautiful. Oh yeah, well, DSA in general.
Oh,
We've
yeah.
got some people up here. But that's not all of you, and we would really encourage you to join us today. This is a really great time to do it while it's on your mind, and we've set up an easy way for you to do it by filling out your pledge card, checking the box at the bottom that says that you would like to join, and you can easily Venmo us at Houston DSA, or send us like some cash that we would gladly accept because that also spends. And then you can become a member right now. Do we have anyone here that'd like to tell us that they're ready to join DSA right now?
It's like church, I'm stepping up.
Yes, yes. I just need you to know that I was raised Baptist and I'm not going to be happy with one soul. So who else here today is ready to join Houston DSA? Somebody's here, I can just feel it. Yes, thank you, Anne. She is the co-chair of our religious socialists, so I'm sure she's loving what I'm doing right now. Anyway, so beyond that, you just got it. Yes.
You get a prize.
You get a copy of the Democratic Left, which is our organization's publication, and this one happens to be dedicated to Medicare for All. So I thank you for that, but also there's more. So we know that there's a problem and that we have to get out and fix it. And in order to do that, we're going to have to get out and talk to our neighbors. So our comrade from Austin DSA told us about the work that they have done, getting out and knocking on doors, and that's how they won paid sick time. So I'm asking that you guys do that same thing. We hope that you're ready to get out and do the work because Houston DSA is. We are actually going to be canvassing tomorrow. We're going to meet at Manil Park at 11 a.m. I will have sunblock, I will have water, and we'll have pizza for you guys. But I won't have comfortable walking shoes to share because we haven't won that kind of socialism yet. And I also, I need people, and we need people like you to do it. So for that reason, I really hope that you'll come out tomorrow, 11 a.m. We'll do a training. It'll be really quick and easy. And then all you end up really doing is going out there and talking to people. And people want to hear about Medicare for All. They want to hear that there's a solution for them. People organize around solutions, and we have one. We have a clear path to victory, and all of you can take part in that. So thank you so much. And I'd like to hear us starting right now making that demand. So can we do it like, healthcare is a human right. 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 All right, thank you so much. Fill out your pledge cards and check on there that you're going to volunteer, and then we'll contact you and let you know when we're going to be doing this. Thank you.